Good afternoon, Dr. Dale Bratzler. I'm the Enterprise Chief Quality Officer for OU Health, and I'm also the University Chief COVID Officer here at the University of Oklahoma. I've prepared a handout that will be distributed that has some of the details that we'll talk about today, and then we'll try to answer some of the questions that have come in. So everyone knows we had 1,373 new cases that were confirmed today. So that puts us up just under 114,000 cases that have been confirmed in the state since the outset of the pandemic, with 1,234 deaths. Interestingly, there were 13 new deaths reported today, but one of the things that I found interesting when I looked at the data was that only 4 of those patients actually lived in long-term care facilities. So a lot of the deaths that we're seeing now are not coming from nursing home facilities and others. The 7-day rolling average of new cases right now is up to 1,221 cases, and that's 1,221 cases per day that we're seeing on average.
Okay. Oh, please.
Sorry, we're having a little technical issue here with the curtains, the blinds in the background coming down automatically. Just a couple of other things. I think it's been a rough week in Oklahoma. We've confirmed 8,548 cases in the last 7 days, and one of the higher death counts I've seen since the start of the pandemic, 80 deaths this past week. A couple of other points to make. When you look at the population incidence of COVID-19, Oklahoma's at 219 cases per 100,000 population. And remember that anytime you have more than 100 cases per 100,000 population, you're in the red zone for the White House Task Force. So we're well above that with 219 cases per 100,000 cases in the past week. I'll talk just a bit about county level data in just a moment when I talk about rural hospitals, but please recognize that COVID-19 now has become a rural disease with substantial spread in our rural communities. If you look at testing, we are doing more testing in the state. Through the first 4 days of this week, there have been more than 70,000 tests completed, and 8.9% of those tests are positive. I think the important thing to know about the positivity rate is that it hasn't changed. We've been flat with the positive rate on specimens tested for the past 6 weeks. That number simply is not going down, and I don't expect our case counts to go down very much until we start to see slower community spread of the virus, which would be reflected in a lower percent positive rate of testing. And of course, the big news this past week is the dramatic rise in the number of people in the hospital. As of yesterday, there were 956 people in the hospital, 873 of those with confirmed COVID-19, and 300 of those patients in the intensive care unit. And even though the quality of care has improved for COVID-19 and we have more treatment options now, when you have 300 people in the intensive care unit, we're going to continue to see some deaths in our state from COVID-19. Some other points I just wanted to highlight. There were some news items that everybody is aware of. Remdesivir did get formal FDA approval for treatment of COVID-19, though I will tell you that while there's pretty good evidence that it may shorten the shedding of the virus and it may shorten the course of illness, the data are very inconsistent yet about whether or not remdesivir will reduce mortality. It's only given to patients who are hospitalized with COVID-19. It does typically require a 5-day course of intravenous treatment, and typically the drug costs around $2,500 for that 5-day course. The other study that I noted this week came out that looked at the impact of convalescent plasma. Certainly, lots of places are using convalescent plasma. There's been real encouragement for people after they recover from COVID to go give blood so that that plasma can be used to potentially treat people with COVID-19. But there have been a number of studies now that have had variable results about whether it helps or not. So there was a fairly large randomized study that came out of India this week, published in the British Medical Journal that showed no real difference in time to severe illness and no real difference in mortality in patients that receive convalescent plasma. There are multiple trials still going in the United States. We just don't have the final answer whether or not convalescent plasma will be useful or not. It may depend on the donor. How many antibodies, how much antibody does the donor have that actually is given to patients? So there are lots of variables that are a bit more challenging to understand, but right now the jury is still out on the benefits of convalescent plasma. I wanted to mention several papers that came out this week that talked about the burden of COVID-19 on rural hospitals. So obviously there's a financial burden. These patients are very expensive to care for, and particularly when you look at rural communities that may have higher populations of uninsured or Medicaid recipients or others, the disease can be quite difficult for them to take care of. Many rural hospitals do have supplies of personal protective equipment, but they may be limited, and many rural hospitals don't have the resources they need provide care to patients who are very sick from COVID-19. And remember, that's at the same time the people that live in rural communities often have more risk factors for severe COVID-19. So generally older populations or populations of people who have multiple underlying comorbid conditions like diabetes, lung disease, kidney disease, and other things. And so that makes it more difficult and more likely that some of those patients will develop severe COVID-19. So I want to then go back to my conversation about the population incidence of COVID-19, and I've highlighted that I think COVID-19 very much has become a disease of rural communities, not just in Oklahoma, but in many states in the Midwest where we're seeing a large number of cases of COVID-19 in rural communities. So I'll highlight Okfuskee County, east on I-40 over where Okemah is. That particular county has the highest rate on a population incidence of COVID-19 of any county in Oklahoma. Now, they don't have the most cases by any means. They've only had about 320 cases of COVID-19, but 100 of those cases have occurred in the last 7 days. And that's what we're seeing around Oklahoma. Many of the smaller counties, they don't account for the majority of cases in the state. That always is Oklahoma County, Tulsa County, Cleveland County, Canadian County, counties that have larger populations. But they're seeing a real uptick in the number of people in their community that are testing positive for the disease. And again, that's why we're seeing the increased need to transfer patients from rural hospitals into the metropolitan areas, because many times those patients have risk factors for severe disease. Finally, I just wanted to highlight and remind people that COVID-19 now is the third leading cause of death in the United States, following only heart disease and cancer. Well more than 200,000 people have died in the United States from COVID-19. So it is ranked as the third leading cause of death in the United States. And again, it highlights for me that we need a more coordinated response, both on the national level and at the state level, to stem the tide, to slow the spread of this particular virus. We need to promote those activities that we know will reduce the spread of COVID-19. So the hospitals in our state are struggling right now in terms of approaching their capacity. In the Oklahoma City area, we went to Tier 2 on the surge plan in the last couple of days. And the hospitals are asking that people do the things that we know will slow the spread of the virus, because if we have fewer new cases, we will be able to offload some of the hospitals. So just to highlight, there are 5 things that I really want people to think about doing. The first, make sure that you're wearing a mask. It's just really, really critical that people wear masks anytime you're in a public setting. And I don't care whether you live in a metropolitan area or in a rural community. If you're going to a place, particularly indoors with other people, please wear a mask. Second, try to remember physical distancing or social distancing. Anytime you can, if you're at the grocery store or anywhere else, pay attention to how close you are to other people, because remember, the closer you are, you increase the risk of transmission of this particular virus. The third thing, avoid crowds, particularly crowds indoors. Now, that's difficult, and I think that's part of the challenge in rural communities where many people live in remote settings and their risk for running into other people is quite low, but they still have to go to the grocery store. They may go to worship services or others where the risk of bringing people together indoors without a mask increases the risk of spread of the virus. The fourth one that I want everybody to remember is that activities that are done outdoors are safer than indoor activities. The virus transmits easily person to person indoors, particularly when people are in close contact and aren't wearing a mask. And then finally, the fifth one, remember what your mom told you, wash your hands, do hand hygiene, do it often, which will reduce the spread of all infectious diseases that we have dealing with. We're at flu season. There already have been a few hospitalizations for influenza this year. Again, we're hoping that we don't have a severe flu season, but remember wearing a mask, physical distancing, hand hygiene, all will help prevent the spread of influenza also, and don't forget to get your flu shot as soon as you can.
All those 5 things that you mentioned made me think about how a lot of the hospitals are having staffing issues, and part of it is that their employees are getting sick, but it seems that a lot of the contact tracing is they're being really good at work. I mean, obviously they have to be, but they go home and there's some of the things they're not following some of these things.
So the question is largely about the staff who work in hospitals, doctors, nurses, therapists, and others that work in hospitals. And I will just tell you that I think in general, in the healthcare community, those people are quite safe at work. And so again, we tell people, if you're sick, if you need to seek care, if you're having an emergency, do not hesitate to go to the hospital immediately, because we're prepared to take care of you. And the hospitals, clinics are safe environments because we're wearing masks. We're doing all the things that we know reduce the spread of the virus. What we're seeing with healthcare workers, though, is that they can potentially become infected, not by what they're doing at work, but what happens when they go home. So just remember that if you're out in public and you're around other people, some of those people may be the doctors or nurses that are providing care to you, and it's very, very important that we try to protect them, protect yourself, and again, remember those public health practices. Avoid close quarters with crowds, wear a mask, do physical distancing.
You touched on this a little bit, but talk about, or Jessica at KOCO was saying that she saw a report that nearly 60% of people delayed non-COVID medical care in the last 6 months. Talk to that.
Yeah, so there have been a number of studies that showed that a lot of people, since the onset of this pandemic, have delayed usual medical care because they've had concerns about going to a clinic or a hospital because of COVID-19 and the fact that we know that we have those patients that do show up in this setting, or they just don't want to get out. It's, again, I just want to highlight again, particularly if you have an emergency, if you're having chest pain, stroke symptoms, anything, call 911, go straight to the emergency room. They are set up to take care of you. You will be prioritized because those are life-threatening conditions. Do not delay that care. But the other one that we're really concerned about is routine medical care, like treatment of high blood pressure, treatment of their diabetes, cancer screening. Are people getting their colonoscopy examinations, mammograms, other forms of cancer screening, and preventive care like vaccines, particularly for children? It's very, very important that we do not forget those things, because a lot of us in the health community have real concern that going forward, we may see outbreaks of patients with more advanced cancer, as an example, because they delayed getting their preventive screenings done. See kids develop vaccine preventable diseases because they didn't get all their childhood vaccines. So it's very, very important that people know that the healthcare community is ready to provide care. It's safe. We have our environment here. As I tell people, I feel much safer and more comfortable here at work than I do when I'm out in the community, because we've got strict policies in place to keep people safe here.
So Cassie at the Frontier was asking about whether Oklahoma has reported excess deaths this year compared to previous years. You talked about some studies about
Yeah, so a study came out this week that showed in the United States there have been a substantial number of increased deaths over the number that are typically expected. So there are techniques where we know what kind of the standard death rate is each year in a population, and we've seen spikes in those deaths that went well above what we would have expected. So obviously in the United States, a recent paper came out that said that excess deaths due to COVID and non-COVID exceeded 200,000 people in the United States. But also, if you go to the state health department's website, look at the weekly epidemiologic report, they have a graphic that shows when they're seeing spikes in the number of deaths that would be considered greater than expected. And yes, there have been more deaths than expected in Oklahoma this year because of COVID-19. Interestingly, Oklahoma's death rate has remained relatively low. We were tied for 20th in the nation earlier this week in terms of the actual death rate per population, adjusting for the difference in the number of people that live here versus Texas, New York, or other states. We tied for 20th, but what we've seen over the past week or so is a substantial increase now in the number of deaths that are occurring. Again, 80 deaths in the past week. And again, remember, the Institute for Health Metrics and Evaluation predicted that Oklahoma would have more than 1,400 deaths by Thanksgiving, and at the current pace, I think we could easily get there.
Okay, reporter News and I was asking if you would go kind of explain the Tier 2 surge plan a little bit more.
Yeah, so one of the things that's happened in the last couple of days is that the Oklahoma City area, which is one of the hospital regions, so the Oklahoma County, has achieved the criteria to be at Tier 2 of the surge plan, which means the following things. There is a hope and an expectation that hospitals will be able to transfer some of the non-acute, lesser ill or less severe patients to other settings of care, for instance, rehab beds or other places, to continue their care and move them out of the acute care setting so that we can open hospital beds. Also, the possibility of expanding the population of people who can take care of patients in those hospitals. So for OU Medicine, that might include many of our administrative nurses or others who don't routinely do inpatient hospital care but may be mobilized to do so that we have enough staff to help take care of patients, or using the Oklahoma Emergency Response medical teams to come in and help take care of patients. And then lastly, each hospital will have to make decisions about whether or not there are elective procedures that they may want to delay or put off to open up beds in the hospital, because sometimes elective operations, obviously, like a hip replacement, those patients do end up in the hospital for a couple of days routinely. And so some of the things that you can do is reduce some of the elective procedures. Again, if you're the patient, I think it's very, very important that Oklahomans understand that if your illness is mild or you go to the hospital or you're recovering, you may get transferred. You could get transferred within the city or outside of the city. I think there was a lot of press yesterday about the COVID patient from the Chickasaw Nation who could not find an ICU bed in the Oklahoma City Metroplex and ended up being transferred to Fort Worth for continued care. People just need to realize that with the surge in cases and the filling up of hospitals, as the hospitals advance in those tiers, that may mean that some patients get moved to other hospitals, other facilities that have capacity. All of that said, I think the hospitals are struggling right now, feeling like there's not good coordination, because sometimes it's difficult to know where those beds are available. We need additional coordination, a statewide approach. The other thing we need, again, if we're going to slow the spread of this disease and not fill up our hospitals and get into trouble, one of the ways to do it is to have a coordinated response to push those public health practices that have been shown to slow the spread of COVID-19.
Can you talk a little bit about the CDC guidelines about cumulative 15-minute exposure?
Yeah, so a bit surprising to us, the CDC changed recommendations for defining what a close contact is to a COVID patient. So we've been working under a definition for quite some time that if a person tests positive, contact tracer will call them and find out people who had been close to them, which was defined as for a cumulative period of at least 15 minutes and within 6 feet. This week, CDC changed that definition to an accumulated time of 15 minutes in a 24-hour period within 6 feet. So, for instance, if I'm around you for 2 minutes now, 3 minutes later today, 10 minutes, later, and within 6 feet, then that cumulative time, if it's more than 15 minutes, that would be defined as a close contact. I think the new definition makes it very, very difficult for contact tracers because many times those times are very difficult to identify. And I just want to highlight that we've had a policy from the outset that 15 minutes is completely arbitrary. There's no explicit science that says close contact happens with 15 minutes of exposure versus 10 minutes versus 20 minutes. 15 minutes is an arbitrary number. Second, if you're in a room, let's say you're sitting at a restaurant with somebody who happens to be infected, you're close, you're sitting at the same table, you don't have a mask on, you could get infected within minutes, if not seconds, if the person sneezes or coughs. So just please remember they've changed the surveillance definition of close contact, which I think is going to be very, very difficult for a lot of our contact tracers to operationalize. But just remember, 15 minutes is arbitrary. If you're around somebody close, they're sick, infected, they're not wearing a mask, you're not wearing a mask, you could be infected within just minutes.
There's an NPR article about how other countries have reopened schools, aren't seeing high case counts. What were some of the reasons for that?
Yeah, so there have been a couple of articles this week that have highlighted that reopening of schools hasn't seemed to be the spreading events for COVID-19 that some people feared. That said, many of the articles that came out focused on a study that was published out of Spain that showed that they did not see an increase in the number of cases when they reopened schools. But you needed to read deep into that study to see what Spain did. It said as long as they were following the measures that Spain put into place. And those measures included kids were all required to mask. In Spain, anybody 6 years of age or older has to wear a mask in school. Second, they divided up the classroom so that they created pods. They brought students, a small pod of students together that they called a bubble, that were then physically separated from other pods of students. And if one of those students tested positive, they quarantined the entire pod. So they weren't quarantining the entire classroom, but just that small pod. The third thing that they did was they really did enforce physical distancing. So I don't think that's happened consistently in U.S. Schools. We haven't seen big outbreaks, particularly in younger kids. But remember, once a kid turns 10 years of age, above the age of 10, they start behaving like adults with respect to infection rates and the ability to spread the virus. Again, I think schools can be done safely. We've done it with the University of Oklahoma. You can do it safely if you do as much as you can to physically separate the students and you have policies that everybody's wearing a mask in the classroom, in the school, which will reduce transmission of the virus. The kids, if they get the disease, they don't get as sick. It's their adult parents and grandparents who are more likely to suffer the consequences of the infection.
This one just came in. At last night's debate, we heard two extremely different views of where we're headed. One said dark winter, and the other said we are weeks away from a vaccine. As a medical professional, what can we really expect in the coming months?
Well, I don't have my crystal ball today, but a couple of points I'll make. I do think there's so I've been listening to some sessions that are currently ongoing in the online Infectious Disease Society of America meeting, and they've talked about the approval of vaccines, It's not going to happen, I don't think, before Thanksgiving, but I think before the end of the year, it's likely that we'll have an approved vaccine. And yes, there are already doses being manufactured, but they will be prioritized. They'll be prioritized when they first come out to healthcare workers, frontline personnel like paramedics and others that are in the face of patients with COVID-19. They'll then be prioritized to places like nursing homes or other places. So a big swath of the population probably won't see an opportunity to get the vaccine until the middle of next year, perhaps at the earliest. So I don't have an exact crystal ball, but we're definitely not done with this pandemic. And we're almost to flu season. And if we see a big outbreak of flu on top of what we're seeing with COVID, then I think we could see a lot of people hospitalized over the next few months. And again, when we have people in the hospital, we're going to see some deaths in our state.
Okay, and just finally, one other person was just asking a little bit more about the flu and how, just some more tips about that.
Yeah, so influenza is another respiratory virus. Spread almost the same way that COVID-19. It spreads person to person, principally by breathing in the droplets or aerosols that come out of somebody else's mouth. The symptoms are quite similar in a lot of people. And we talked about before that loss of taste or smell is very unique to COVID, and you don't see that with influenza, but most of the other symptoms can overlap substantially. And both viruses can cause patients to get sick enough to need to be in the hospital. It turns out that it still appears that COVID-19 has a higher mortality rate than influenza, and it is possible, we know from early part of the pandemic, that you can be infected with both viruses at the same time. So again, I'm urging everyone, get your flu shot this year. If you've never done it before, it's very safe. Get your flu shot because you don't want to come down with COVID and influenza at the same time. And if you've had your flu shot, then it reduces, it makes it easier to distinguish when we see a patient that has those symptoms that overlap so much.
That's it. Anything else?
Nope. Thanks for participating.